I have with me Professor Carol Peden from the UK, and she's an expert in quality improvement. And what we're going to discuss is emergency laparotomy pathways, which she's had a huge amount of input into in the UK. So, Carol, how do you think enhanced recovery principles can be incorporated into emergency surgical pathways?
Thanks, Mike. I think a lot of the principles of enhanced recovery, the standardisation of the pathway, the reduction in variation, empowering multidisciplinary team members to take action are all very important. I think there's perhaps been a tendency in the past to think that these things can't be applied to emergency surgery, but I think we've seen success with fracture neck of femur pathways, and now we're trying to implement them for emergency general surgery. So I think the themes that you see in enhanced recovery are very applicable for many aspects of the emergency surgical patient.
I noticed in your lecture you had 5 main points which were important for implementing. What were those?
Early recording and action on an early warning score, ideally within 30 minutes of the patient arriving in the hospital. Early appropriate antibiotics and assessment of whether the patient is septic or not. From the decision to surgery to the operating theatre, this is for emergency and urgent patients, should be within 6 hours. Obviously, true emergencies may need to go within the 1 to 2 hour window. Goal-directed fluid therapy intraoperatively, and then intensive care or a critical care bed for all patients post-operatively. That last one can be a little bit of a stumbling block because people say they may not have enough critical care beds. In my hospital, we don't, but we've managed to increase the number of these patients that go, and I think it just promotes a different way of thinking about the patients, that they're very sick. And even if we can't get them into a critical care bed, we should be keeping a very close eye on them post-operatively.
Right. We talked about enhanced recovery, and we know that that's evidence-based really on colorectal surgery, and although there are other guidelines coming out with pancreas and rectum and wider specialty areas, is there anything that you think is truly evidence-based that we should be implementing straight away?
Well, I think the Cochrane review led by Mike Grocott and his colleagues showing that there is benefit in the high-risk surgical patient. I think that is applicable to this group of patients. There's hardly, other than a ruptured aortic aneurysm, there is no higher risk group of patients than these. And the mortality has remained high for many years. Therefore, I think if we have something that could add benefit, we should be doing it. I think the other things that I've mentioned, early warning scoring, antibiotics early when appropriately, and assessment of sepsis, and are very evidence-based. The evidence base for admitting high-risk patients into critical care is harder to prove, but I think the evidence is really massing that these patients do need that level of care.
You've been involved in a project in the UK called ELTQuick. What advantages has that brought to patients within that quality improvement study?
Well, it stands for Emergency Laparotomy Pathway Quality Improvement Care Bundle. Just came together nicely as ELTQuick. And really, this is a very high-risk group of patients, which a number of papers have shown the mortality varies between 15 and 20% and even higher for the over 80-year-old patients, and that's at 30 days. If you go out to 90 days, the mortality remains very high, and up to 25% in the high-risk group of patients overall. So this is a patient group that really needs action, and we've just implemented a simple protocol using evidence-based steps. We've concentrated. There are lots of things we could have acted upon, but we took things that we felt were easy to implement in the immediate perioperative environment. We've looked at improving our reliability, and we've tested it across 4 hospitals, and we all have improved. All 4 hospitals have improved. We still have a lot more improvement we can do, but we have seen a significant decrease in mortality in the over 75-year-old group of patients. The unadjusted mortality has fallen in all the hospitals, although not necessarily significantly, but when you adjust it for the patient's comorbidities using a P-POSSUM score, then we have shown a significant improvement in outcome. Certainly in my hospital, I can tell you the figures that we were averaging 15% mortality prior to the study, and we're now running at about 5%, and we've sustained that for the last 6 months, which is a huge difference. Yeah,
that's very good. Omar Faiez's work sort of suggests that in the over 80s, there's a subgroup where emergency laparotomy is really just almost an end-of-life presentation. Is there any way we could try and stratify this group to whether they actually go for surgery, what sort of care they get? Any ideas on that one?
Well, I think there's a more general issue around patients making their wishes known in the community, so that we aren't offering very high-risk surgery to patients when they're not able to make their own decisions very well because they're septic or confused, and when perhaps they would not have wished to take that risk. So I think that's one thing. I think there's also something about, and one of the things that we're hoping to do in the 4 hospitals in the ELP-QUIC study is to look back with structured reviews at the patients who have died and look to see what processes of care could have been done better, and whether there were some predictors of when outcome would be extremely poor or fatal for those patients.
ERAS prides itself in it's a multidisciplinary delivery group. Are there any particular groups that you'd like to bring into the emergency laparotomy pathway?
Well, I think some of our success has obviously been with we've had a very good nurse researcher, certainly in my hospital, who's got the post-anaesthesia care unit nurses involved. And if we haven't been able to admit patients to a critical care unit bed, we've run the goal-directed fluid therapy post-operatively in our post-anaesthesia care unit. And so that group of nurses has been very important. And also our ICU critical care nurses have come on board. So I think nurses play a very important role in this. Further down the line, it might be the care of the elderly physicians to assess these patients and help with the consent preoperatively, and then also immediately postoperatively pick up on management of delirium, the common cardiac complications that we see, and really start mobilising and improving these patients' outcomes perhaps for the longer term, because we don't know much at the moment about how these patients feel when they get home. You know, did they feel that this massive surgery was worth it, particularly in the very elderly?
Well, thank you, Carol. It's very interesting points on what is an increasingly important area of healthcare. And there's obviously lots of work to be done and improvements, and congratulations on the work you've done so far, and we're looking forward to you presenting further data in the future.
Thank you, and I'd just like to thank all the team members who've helped get this study this far. Thank you.